Hello and welcome to the fourth presentation in our 6-module series in the Build a Clinic program on key components for implementing tobacco-free policy, including tobacco services. My name is Mary Mancuso, and I am a clinical associate at the Behavioral Health and Wellness program. Today we'll be talking about the best practices regarding analyzing and adapting your clinical workflow to accommodate new or expanded tobacco cessation services and supports. So before we get too far into the broadcast, I wanted to take a few minutes to do a little bit of housekeeping. For those of you attending all the Build a Clinic webinars, you will remember from the last time we have gone to a computer and internet-only webinar format. This worked out really well last time, and thank you so much for those who chatted in their questions and participated in our follow-up evaluation. Please take a moment to mute your computer's microphone. We will also be muting everyone on our end, but occasionally we may unmute to receive input. At that point, it would be nice not to hear all the background noises like traffic or dogs barking. So thank you for that. If you do accidentally close out or get kicked off during the webinar, simply re-access the link in the confirmation email you have received and rejoin us as rapidly as possible. Please send in your questions as you think of them using the chat function built into the webinar software. We'll probably take questions and answers at the very end of the webinar. And we will take some time for that. So today's presentation is the fourth in a 6-module series covering the knowledge and skill practices you need to know how to effectively and efficiently integrate tobacco cessation services and supports into your clinical workflow. And we will have a special emphasis on serving rural or otherwise underserved populations. These webinars have been and will continue to take place monthly. The first webinar covered the 5 A's, a clinically proven best practice used to move patients through the stages of change, motivate quit attempts, and remain abstinent longer. In the second webinar, we discussed pharmacotherapy options. Combined, the first two presentations provide the basic skills necessary to begin treating nicotine dependence right away. For the third webinar, we return to counseling with an in-depth look at the use of motivational interviewing within the 5 A's framework. Today, the University of Colorado Department of Family Medicine will discuss workflow and how tobacco cessation fits into a typical clinical workflow to find low-burden ways to integrate tobacco cessation interventions into existing practice. Next month, we'll introduce the whys and hows of tailoring tobacco cessation interventions for populations specifically targeted by the tobacco industry and those populations that, although may not be specifically targeted, tend to lack the preponderance of services that frequently lead to more successful quit attempts. This presentation will focus on cultural sensitivity and how the use of motivational interviewing can make clinicians more adaptive in the face of our increasingly more diverse and ever-shifting populations. Finally, we will look at the internal and external resources that can be brought to bear on this new program so as to create a sustainable culture of wellness. The first 3 webinars in the series are available as videos on our YouTube channel. You can access them easily by visiting our website, bhwellness.org, look under the Materials tab, and then select Build a Clinic Materials. Today's webinar, like all Build a Clinic webinars, will be available on that page 2 weeks from the broadcast date. And this is me. Just a little bit about my background. I have a master's degree in counseling psychology and have over 6 years experience working in both behavioral health care and hospital settings. And our presenters today are Drs. Chandra Brown-Levy and Matt Simpson. Dr. Brown-Levy is a licensed clinical psychologist and Director of Integrated Services for the CU Department of Family Medicine. One of the department's focal areas is smoking cessation. Health coaching, including tobacco cessation coaching, is delivered by staff who have extensive training and experience in health-focused clinical and behavioral strategies. The department is testing cessation workflows, including electronic medical record, EMR integration, treatment planning, on-site consult, referral models, and telephonic follow-up. Dr. Simpson is a family doctor who practices at Denver's Rose Medical Center. He is also an instructor within the Rose Family Medicine Residency and coaches residents on quality improvement and practice transformation. Specifically, he has helped to develop and evaluate a smoking cessation workflow as part of a residency quality improvement project. Additionally, he spends half of his time as a research fellow in the CU Department of Family Medicine with a focus on practice-based research, working to implement research projects in primary care practices in Colorado. Today we have three main objectives. Number one, to understand best practices for workflow development and analysis. Number two, to identify important variables to define and determine success. And number three, to identify and explore specific tools for tailoring a strategic plan for clinic change. Every community is different. Some communities are seeing worsening trends in obesity, diabetes, cancer rates, or any of a host of other problems. Some of this is due to the so-called gray wave, the wave of baby boomers moving into senior status. Some of this is due to having solved so many other problems, especially those directly or indirectly caused by infectious diseases and foodborne illnesses. In any case, the biggest target of most primary care practices is moving away from treatment of acute illnesses and injuries and toward the prevention and maintenance of chronic illnesses. Whatever disease or set of diseases your clinic is most concerned with, there is a better than 50% chance that tobacco is involved and that prioritizing the treatment of dependence can help. Tobacco is a contributing cause of all 5 of the top 5 killers in the U.S., which include heart disease, cancer, respiratory disease, stroke, and accidents, including accidental house fires. Because these conditions require a certain amount of health literacy to understand the causes, consequences, and treatments, and because the need for surveillance and maintenance never goes away, the necessary level of patient engagement and clinical support is high. Furthermore, while different conditions often require specialized knowledge and skills from both clinic staff and patients, it's also true that many of the fundamental skills remain constant across conditions. As such, for example, the 5 A's, while initially developed to help treat nicotine dependence, have been expanded and revised to treat a host of chronic conditions, including diabetes, obesity, and dietary and exercise habits. Similarly, we encourage all practices to incorporate whatever principles are already in place in your clinics to treat your patients' chronic conditions and simply include tobacco in the mix of things you are willing and ready to talk about, track, and treat. So you've likely seen this slide before, and we're not going to walk through it, but want to remind you that as you hear Drs. Brown, Levy, and Simpson discuss the methods, tips, and tricks associated with analyzing and adjusting your workflow, the tobacco cessation touches on all aspects of a clinical experience and requires input from various sectors, from intake to follow-up. Rather than thinking of it as burdening one person at one time to carry the entire weight of an intervention, think of it as a simple and regular engagement about the patient's overall health and wellness. In this way, your intake person is asking about tobacco use. The highest authoritative person the patient engages with is advising them to quit. Someone who can spend some time with the patient explores their relationship with tobacco and assesses their level of dependence and their willingness to quit. The same person, or maybe someone else, explores with the patient their potential barriers to quitting tobacco and assists them in designing an individualized quit plan that may first include stepping down and adding NRT before hopefully setting a quit date and managing triggers and cravings. Someone then arranges a definite follow-up visit with the explicit intention of checking in on the patient's tobacco use and their success at meeting their tobacco-related goals, whatever they may be. This workflow, as well as other information, is detailed in the Workflow Toolkit freely available for download on our website. Keep this framework and general idea in mind as you listen to Drs. Brown, Levy, and Simpson today. And with that, I turn it over to Dr. Brown Levy.
Thank you. All right, let's see. I'm going to advance this slide. Do I click over here? Let's see. There we go. Okay. So thank you for having us today. We are happy to be here. Just to get us started, you're likely here because you want to move tobacco cessation forward in your organization. And it's often difficult to know where to start, and it's really easy to get stuck at various points in your efforts. So today we're going to talk about some of the things that we have tried to do and hopefully give you some frameworks for things that you could try to help you move forward regardless of where you're starting from. So let's see. Can we move to the next slide? Am I able to do that? Okay. So wherever you are, chances are you are not alone. You may not have resources or haven't identified resources and you're not quite sure where to even begin the process. You may know who to refer your patients to or clients to for help with smoking cessation, but then you don't know if they ever follow up. You feel like you're kind of left in the dark and you're never really sure where things are in the process. You might have resources on site and you might be coordinating with other sites or other services, but then you're not sure how to best work with those other resources and services and sites. So it might feel a little clunky, or it might feel like it's going pretty well, but you can think about ways that it could go even better. So wherever you are, you're not alone in that process. Okay. Go to the next slide, please.
All right. So where to begin? Luckily, in the context of this project, we already have a starting point identified in focusing on tobacco cessation. But in general, we want to provide you with the framework for how to move forward with other QI initiatives beyond this project. And our goal of the webinar is to kind of equip you with the general scaffolding so that you can go on and implement this in other areas as well. So in general, when thinking about areas in which to begin, one way to think of it is in alignment with other initiatives that your clinic is pursuing or interested in pursuing. So both Chandra and I have had experience using this for our patient-centered medical home process and application, and using it as a clinically important condition in some cases. Another potential avenue would be to incorporate this with a lung cancer screening initiative that's going on. Other ways to identify issues within clinics are trying to address those hotspots, known issues, and pressure points. So these are the ones where when you're in clinic either get under your skin or your colleagues' skins and you hear people complaining about. It's what people talk about in the break room. It's the sort of squeaky wheels in the clinic. You can also look into other existing incentive programs, and then as well as a personal or clinical interest in any of those areas. Next slide, please.
Okay, well, this is a slide that is part of the Lexicon for behavioral health and primary care, and I think that this is a really nice framework to help you move forward with change efforts. So in the emerging field of behavioral health and primary care integration, it became apparent that we needed to develop some shared language that enabled communication and collaboration across sites, disciplines, and time. So the Academy's Lexicon for Behavioral Health and Primary Care Integration created a set of concepts and definitions, which was developed by expert consensus for what we mean by behavioral health and primary care integration, or created functional definitions of what things could look like in practice. So this consensus lexicon enables effective communication, as well as action among clinicians, care systems, health plans, payers, researchers, policymakers, business modelers, and patients for working towards effective and widespread implementation on a meaningful scale. And so this lexicon can also be used to help you move tobacco cessation forward in your organization. So starting at the top, first is identifying a core planning team and leadership support. Along with that, everyone should be given the opportunity to be involved in the planning process. Everybody who could potentially be a part of this initiative that you're working on. Part of this is also determining buy-in and support, where you can identify champions in multiple areas needed for the success of your proposed improvement innovation. And culture is a really important piece of this, so that everyone understands the why and the how, which can help enhance chances for success. So if every person from the front desk to the medical assistant to the primary care doc, if you have pharmacy or behavioral health or coaches, nurses, if all of those people don't understand the vision of what you're trying to do, then your improvement efforts are going to be that much more difficult. So they might just see your ideas as more work for them. So it's really important to make sure that your vision is defined, the type of collaboration needed to ensure success is clear, and that you have assessed organizational capacity, including current resources, and how your vision and efforts fit with what the practice needs are. So alignment in these areas will greatly enhance your likelihood for success. The other key component is communication. It's always communication. So communication strategies should be outlined to ensure monitoring of day-to-day management challenges so that they can be addressed in a timely manner and in a team-based way. Next slide, please.
And this slide just drives home the point that Chandra illustrated, is that you really need to have a broad, inclusive definition of potential team members. So the key here is not to go it alone. So we really want to talk to everybody who works inside the walls of the clinics, the patients that you serve, as well as potential community stakeholders to really engage in this team. Because if you try to implement a change on your own or with a smaller group that doesn't have representation from other key members of the organization, then it's likely that the workflow is not going to progress as planned. I really put front desk and medical assistants as the top two on this list because in my experience they have been a valuable source of information with a wealth of experience to really help drive quality improvement forward in my clinic. I think about it in a typical clinic day, I'll see 10 to 12 patients per half day. The medical assistants probably have about 25. The front desk is closer to 50 to 100. And they have that experience and exposure on a much more frequent basis than I do, and they're able to really identify a lot of things. Now, I know some of you might be in smaller practice environments, and so if that's the case, then I think you should think externally as well about any partnerships with local public health, with pharmacists in the community, with patient advisory council, and trying to get patients engaged in the quality improvement workforce. And so I think the key here is just to try to think broadly about your potential team members, and in one of the later slides we're going to talk you through how to select team members for your planning team. Next slide. So defining the question. This is key. Everybody wants to improve tobacco cessation in their clinic. But if you think about that type of a question, that's a tough one to measure as it's currently phrased. And so we really want to boil that down into a more measurable outcome. Think about it whenever you're kind of counseling any patients on goal setting. You always want them to have a measurable goal. You don't want them to just say, I want to be healthier, and leave it at that. So same thing applies to quality improvement. Don Abedian was one of the founders of measuring quality in the healthcare system, and he developed this framework of quality measures that includes structural measures, process measures, and outcome measures. So structural measures are a measure of human and material resources available. So this was done most often in the context of hospitals, and it would say, does this hospital have an emergency room that's staffed 24/7? Does it have a cardiac cath lab? But if you look back at the tobacco workflow from the beginning that you guys have a copy of, there is a structural measure in there as whether or not your clinic has tobacco cessation materials available in the waiting room. So sometimes a structural measure, while it doesn't always correlate to an outcome measure, it can be an easy place to start. Process measures are really where a lot of focus right now is given in primary care. And the process is just broadly defined as any healthcare-related activity. So an example of this would be the proportion of patients that are seen in your clinic that receive tobacco cessation assessments from the medical assistant or that receive counseling. And so these are a little bit easier to measure than outcome measures, but a little more in-depth structural measures. And in the current clinical environment, rely a lot on the ability to extract data from electronic health records. Outcome measures, on the other hand, are really defined by the health state of a patient. In the context of this project, really looking at the number of patients who are tobacco-free and living tobacco-free lives. That one is perhaps the hardest to assess in the clinical environment, and that's why it's not used as commonly in quality improvement work. The hope is that the process measures really tie faithfully into outcome measures, but that's not always the case. And part of the reason for that is because of variables that are outside of the control of the clinic, the healthcare team, and everybody else. So I think you all know this, but with tobacco cessation, the healthcare team can do everything that they want, but if the patient does not want to quit smoking, then that may not ever happen. And so that's why a lot of people focus on process measures, because it sort of defines a reasonable set of expectations that a healthcare team can do, recognizing the limitations of being able to control all of the different health outcomes. So for this project, I think process measures are going to be one of the ways to go, and we'll talk a little bit about how we use those in our clinic in just a second. The other thing to think about is satisfaction, and this is, of course, also becoming increasingly important in the healthcare environment with a lot of satisfaction surveys. And so this comes from both the patients, providers, and the staff in thinking about your intervention as to how it will affect these domains. Even if it's not a primary measure, I think it's important to think about, because if you implement a workflow that is going to decrease satisfaction in any of those three key groups, then it might be less likely to succeed. So even if you don't choose to measure it formally, I would advise thinking about it. Lastly, if you want to just take some definitions off the shelf, you could go to NCQA with their patient-centered medical home list and use some of their checkboxes straight off the shelf and go that way. And then the other things to look at in general with quality measures are cost of care and utilization. Those are typically done on the more payer scale as opposed to the individual clinics. Next slide, please. So once you've decided where to begin, thinking about your intervention as well as how you're going to assess it, it's important to then link it into this quality improvement framework. We use the PDSA cycle in our clinical practices, though there are some other options to do. And in this one, it stands for Plan, Do, Study, Act. And the real key for this is to recognize that quality improvement is both a continuous and an iterative process. So you can spend a lot of time planning, doing, and assessing, and then you could fall into a state where you did something really well, and then you stop doing it. And so the goal here is to sustain it and continue the quality improvement work. So I often think of this as a flight plan, and once you're midair, trying to be able to adjust for course corrections in case the storm rolls through, there's increased traffic at the airport and everything like that, so that you can stay nimble and flexible as a clinical team to continue to get the outcomes that you want. So the key here is that when you're planning the intervention and then subsequently go into intervening and study all the outcomes, is the ACT stage is really, I think, the crux here, where you take the data on what you just studied and you use that to inform the next cycle. So that's where it links it into an iterative process. Because a lot of times if you do an intervention and see no change, then people will either give up and never try this topic again. But a lot of times the failure to show improvement has a rich source of information to inform the next round of the PDSA cycle. Next slide, please. So we're going to tell you some stories from our own clinical experiences, and while we do that, we want you to keep these different questions and elements in mind. So our clinic at Rose serves an urban underserved medical population, and we have done several different projects around tobacco cessation over the last decade. Before I even started, we had a really successful program in place that achieved some level of national recognition for improving tobacco cessation rates in our clinic. Then we had some competing demands emerge. We went for patient-centered medical home certification. We switched from paper charts to an electronic health record. We had some turnover in staff, leadership, faculty. And all of a sudden, this really awesome program that we had around tobacco cessation fell not even to the back burner, but completely off the stove. Now that we've kind of got a better grapple on PCMH as well as our electronic health record, there's been some reinvigorated interest in this project. So this previous year, we had a resident champion for her quality improvement project implement a tobacco cessation workflow. It started with the medical assistant handing out a survey to every adult patient that they roomed that assessed their tobacco use and their degree of dependence. It also assessed their interest in potentially quitting. At that point, when the healthcare provider entered the room, he or she was supposed to take the survey, review the results with the patient, and arrange for follow-up, either through the quit line or through nicotine replacement through the clinic or through a behavioral health provider. At that point, they were also supposed to arrange for a follow-up visit to come back into clinic and see how successful the patient was with the various interventions. In reviewing the data over the last year, we ended up having approximately a 70% screening rate for tobacco cessation, which was significantly lower than what we had hoped for. And we kind of reviewed the data in the context of the larger clinical environment and really figured out that one of the bigger competing demands in the clinic was the fact that there were 3 other quality improvement projects happening simultaneously. And we were telling the MAs to add so much to their workflow that they couldn't necessarily address every quality improvement project at the same time. So now that this resident's graduating, she's going to hand the baton over to somebody else to try to now act on the data that we got this year, plan a different intervention, and move forward with another PDSA cycle. Chandra?
Yeah, so in our practice, we're in an urban residency practice. It's a level 3 PCMH practice, and you know, similar to what Matt just described to you, we've gone through various iterations and time points of trying different things. Currently, for tobacco cessation in our clinic, we are aligning these efforts with our existing PCMH efforts and our CIC meetings. So CIC is the clinically important conditions. So along with this, what we do is we have multidisciplinary meetings. We meet monthly with multidisciplinary teams to determine needs and resources and provide regular feedback to one another as to what is working, what isn't working, so that we're continuously improving practices. So constantly going through that PDSA cycle pretty much on a monthly basis. Currently, we are having our medical assistants do an initial verbal screening and then provide counseling options to our patients. So then based on the patient's preference, so things like maybe they want to discuss you know, cessation further with their primary care physician. Maybe they don't. They prefer to get information about the quit line. Or maybe they'd like to be connected with a health coach. Or maybe none of those options sound good. They'd rather just get materials and think about it on their own. And no matter where they are, that's fine. So that's why we give them options, and then we'll provide additional support, trying to meet them where they are. And then all of that information is documented in our shared electronic medical record. So we know who last worked with the patient regarding tobacco cessation, what the patient's level of interest was, and what supports were put in place. Then we use registry support for appropriate and timely follow-up with each of those patients. The other thing that we've done in trying to develop what are the options that patients would be interested in. If we developed written materials, what should those materials look like? We involved our patient advisory council in developing all of those materials and options. So also I think making sure that the patient is part of this process can be hugely important, and it can show you where some of your blind spots are. So I would also say, bringing your patients into your conversations and your quality improvement efforts as much as you feasibly can is always a great idea. Next slide, please. So this is a quote I really like, and it helps us kind of parlay into the next component of our presentation today. We're going to shift gears a little bit and direct you to an article that appeared in the Journal of Integrated Care Pathways in 2007. It's a paper that provides a great framework to guiding change work. It helps us frame where we see blockages to implementation of change, and then how to make change happen in a variety of different ways. So that's what we're going to do next. So next slide, please. Okay, I hope that you can see this matrix here. If it's hard to see, there is the reference at the bottom there, so you can get the full paper if you go to that reference there. So one of the things that I think is important to start off with here is talking about influence. Influence is not a one-off event. It's a process. It takes time. It needs to be managed. It involves getting people in different positions in the organization on your side to accept your idea, support your idea, and any of these people can delay or prevent an idea from being adopted in lots of different ways. So a key set of activities at each stage of the care pathways continuous improvement effort must support a campaign of influence. So this is an interest power matrix that can help you focus your efforts on key individuals. And so kind of just walking through each of these boxes here, taking a look at players with high power but low interest. These are people that should be kept satisfied with regular updates and confirmation of how the initiative will benefit the organization without adversely affecting them. This helps to ensure these players do not become concerned or alarmed and then act against the initiative. If that is to occur, they would then move to the key player box, and it would require additional time and energy to persuade them to support you. So you may want to work to win these people's interest, since their power could be very helpful to you. Players with low power and high interest should be kept informed to reduce the risk that they become upset and start a counter campaign. Keep these people adequately informed, talk to them to make sure no major issues are arising. These are also people that can be really helpful with the detail of the care path under initiative. Players with low interest and low power require minimal effort on your part. It's pretty unlikely that they'll influence the final outcome. You'll want to monitor them, but don't bore them with excessive communication. That might become annoying. And players with high power and high interest are the ones that are going to require your full attention. You'll want to engage them fully and make the greatest efforts to satisfy them. Next slide, please.
So if you find yourself in a situation where you don't have a lot of people with high interest in something, you can use this Motivators Matrix to help garner interest. And the real key behind this matrix is understanding everybody who's in your clinical team, what makes them tick, and what's really important to them. So I think we're past the days where clinics were a place just to go to work, but are really a key team development location where everybody gets to know each other on a little bit more of an intimate basis in order to improve the clinical care that's delivered. So starting with the key motivators under the idea of personal development, this one's been really important in my quality improvement work in my clinic because I found a lot of untapped resources in the personal development plans of our medical assistants, front desk staff, and clinic nurses. So getting a sense of not only why they come to work every day, but where they want to go in a few years is so important. We use this on a project where we have one of our medical assistants who's really interested in eventually applying to physician assistant school, and we engaged her in some work that was really interesting to her that would also help her to achieve that goal. So figuring out that, who is interested in what and what projects you can plug them into is important. Of course, that's not enough, because you also have to think about the motivation conditioners or the environmental factors that are at play. So for example, the working environment, if people are coming in at 7 a.m. and staying until 7 p.m. With full-time clinical duties, it's going to be very hard to engage them in quality improvement work no matter how interested they are in it on their own intrinsic level. Furthermore, with their wages and salaries or fringe benefits, a lot of times this is outside of the control of the people on the quality improvement team. That being said, I found that free food can be a really strong motivator there. If you're asking somebody to do extra work, particularly if it's over lunchtime, to provide a meal for them so then they can free up some of their time to work on the project. And then I think security is really important, and this is not the physical security, but more a sense of team dynamics and making sure that you approach this from the lens of enabling leadership, where you enable everybody on the team to participate fully, share all their ideas, and they don't worry about any reactions from other team members, and that there's no hierarchical structure in place. This has really freed up a lot of our front desk staff to drive some quality improvement projects in our clinic. I think is a really important environment to keep. So if you're finding that you're having a hard time garnering interest for your workflow and quality improvement project, I would go to this and think about which factors are potentially inhibiting it. Next slide, please. And this is one of my favorite slides because I think it provides such a nice summary of blockages to implementation in the quality improvement process. So the key here is across the top are all these factors that are necessary but in and of themselves not sufficient to lead to improved outcomes. What that means is that you need to have at least a minimum combination of all 5 of these areas in order to achieve success. So first, under pressure, there has to be some degree of pressure for change. This one, of course, has to be a careful balance because you want it to be urgent but not emergent. You don't want there to be a sense of panic instilled by it. But that being said, if you don't have pressure in your organization, then this quality improvement project is always going to be what they call the bottom of the tray. It's always going to be a low priority on the list, and it may not ever make it to the top where it actually gets addressed and worked on. Vision is so key because you all have to have a shared idea of where you want to go and how to navigate there. I think of this as setting the destination on your GPS so that you know when you've arrived. The part here that is perhaps understated a little bit is that it has to be shared. So if the vision just lives in one person's head, it's not really a vision. It has to be a vision across the entire team. Now without a vision, you get what's called a fast start that fizzles, meaning that you can take off, you have pressure, tactics, skills, everything in place, but then all of a sudden you're 2 weeks into the project and you're like, wait a second, where are we going? Why are we doing this? And all of a sudden there's a quick burnout that doesn't sustain. Tactics. This part is important because it allows you to really engage all the key members within the organizational leadership structure and get everybody's buy-in. So the key here is that you want to have an engagement strategy that encourages input from everybody that's taken seriously. So I always think of this idea of coming to meetings where the decision's already made and people are just telling you what to do. And those meetings put me off a little bit. So you really want to figure out a way to have some tactics and encourage people to change. And part of that is just engaging them in the process and feeling like they have a role. Skills. That's hopefully what we're going to deliver to you through the 6-module series. So for example, if you had some pressure around tobacco cessation, a clear vision for improvement, you have everybody engaged around it, but you don't have principles of prescribing nicotine replacement therapy. You don't have principles of motivational interviewing. You don't know about the 5 A's, then the problem is this could lead to high degrees of anxiety or frustration. This would end up in a pretty bad situation, perhaps one of the worst of all of them, because trying to reinvigorate efforts after you get to that level of anxiety and frustration can be really hard, because everybody will say, we've done that once, it was terrible, I'm not doing that again. And so hopefully we can impart those skills on you through this series of webinars and echo sessions to help everything out. Lastly, first steps, and I've seen this one happen a lot in my experience. I'd say this is perhaps one of the more common stumbling blocks that people have, and part of the reason for that is you have to boil a complex and nonlinear system into a next actionable item to work on. Otherwise, what's going to happen is you'll waste your efforts in a lot of different directions and not really have a clear first step to take, and everybody's going to feel a little bit burnt out and unsure about what to do with their role and where to go next. And so I'd say, kind of getting back to the quote about putting things in place before they begin, is really think about a first step. And my encouragement here is for our first PDSA cycle is to really choose an intervention that's feasible, find a measurement that is pretty easy, kind of a light touch on the clinic, and likely to show some improvement, and then you'll be able to sustain that energy because you'll have a relatively easy intervention that works that you can then use to garner more buy-in and support. So don't be too hasty in the first step category. Next slide.
So I think that through these strategies, one of the things that this can help you do is create a burning platform. Basically, create a circumstance or a series of circumstances, situation, change culture that will give you a greater chance of success. It takes a lot of time, energy, a lot of support to do that. But ultimately, you'll get to a place where all of a sudden everybody's on board. Everybody sees their role. They can see the vision. They feel like they have some skills, they can be helpful, and all of a sudden people are on board. Getting back to kind of our storytelling a little bit, I can see how this has happened through our PCMH efforts throughout the years. We've gone through the recertification a couple of times, and when we first did this, people, they weren't quite sure what we were doing, what their role was, how this was going to influence them. There was a lot of that anxiety. There were a lot of people who, you know, kind of wanted to put some barriers in place because change can be really scary. But now I look around and I see people who are so engaged in the process. They're always looking for ways to improve. The questions are different. The questions aren't regarding, you know, how can we stop this from happening? It's more, how can we continue to do this and do it better? And what is my role? And how can I work to the top of my skill set to continue to make this better? So I think, you know, thinking really strategically about your specific work culture and circumstances, how can you set the stage for improvements that will give you the best chance for success. There's all of these different elements. It's incredibly complex. It's very difficult. So we might give you, you know, charts and graphs and stories, and then you try to actually implement it, and it's really hard. So I don't want to underplay that, but I do hope that some of these concepts and strategies will give you ideas about how to navigate the challenges along the way so that you will have the best chances at success. You know, we're specifically talking about tobacco cessation efforts today, but I think you could probably see the application across multiple change efforts. Next slide, please. So this is a picture that I often refer back to, just kind of a motivational picture and a quote, the road to success is always under construction. You know, it's not, it's continuous PDSA cycles. It's always trying to look at those power matrix components and figuring out how can you continue to support your organization, the people within your organization, to deliver excellent care and do the best job you can to help people be healthier, but do that in really strategic ways. So we know that these efforts are challenging, but it can also come with a lot of reward, and we really appreciate the time that you spent with us today. We hope that some of the things we said today will be helpful to you. Next slide, please.
So thank you so much, Drs. Brown, Levy, and Simpson. I do want to take a brief moment that many of these issues and more are discussed in depth in several of our toolkits, the two most relevant of which are Dimensions, Tobacco-Free Toolkit for Healthcare Providers, and a Patient-Centered Tobacco Cessation Workflow for Healthcare Clinics. Like all of our toolkits, many also available in Spanish are available freely for download on our website, bhwellness.org. Look under the Resources tab under Toolkits. And for those of you interested in applying for the next round of the Build a Clinic program, please check our page. The next round will begin shortly. In addition to these public webinars, we are also providing tailored technical assistance to a limited number of selected applicants. Requests for applications will be going out soon, and if you want to be included in the request for applications mailing, please email us to let us know. And if you have any questions, you can email Jim Pavlik, Program Manager for Build a Clinic, directly at the address that you see on this screen. And with that, we will turn it over to questions. And for those of you who are attending the webinar, just please type any questions that you may have in the side panel on your screen, and we will answer them.
All right, so we just got a question here in the chat box asking, what is the average time to anticipate seeing the adoption of change in your experience? So the first part of the answer to this is it varies a lot. Depends a lot on whether or not this is an experienced team that's implemented many improvements before, or if this is the first go at it. But I think the real key is that it takes longer than I would thought. I've had many experiences where I thought something would be a pretty simple process to improve, and when I went to go and try to do that in my clinic, it just showed a lot of my blind spots of things I didn't anticipate, downstream consequences, how it would affect other people's workflows. And so my general sense is that to get to a level where you're adopting it, using a workflow regularly, and sustaining it can be about 6 to 9 months. Is that similar, do you think, to your clinic experience, Chandra?
Yeah, absolutely. I mean, I think it definitely also depends on the size of your organization and the complexity of your clinic. I've seen in smaller practices that sometimes they're a little bit more agile. They can implement change processes a lot quicker. If you're part of a really large organization and you're trying to perhaps make some changes in your electronic medical record, things like that, and you need programmers and you need people to buy into how a certain language is, sometimes it can take much longer. So I could see how, in a very small, agile practice, maybe you could do something really quickly, a month or two. In larger organizations, sometimes, you have to just really practice patience around this and remember why you're doing it in the first place to continue to fuel that fire for change. And that being said, sometimes if it's a really small change, even in a large organization, it can happen quickly. When you're trying to do a big change, sometimes it can take years. So again, I think it comes down to strategy. And also leadership buy-in. If you have leadership buy-in at multiple levels, things can happen very quickly. It's nice to have friends in high places.
All right, looks like the next question we have is, do you have any tools or frameworks that you like to use for keeping timelines? This could help to keep a team on track to set the small achievable goals that you mentioned. Any advice? Yeah, there are a couple of frameworks I use a lot for this type of timeline and accountability type of process. One way is just a simple Gantt chart. So the idea that you have everything broken down by month and what you're going to accomplish each month. And then you can assign members to each of those subtasks. And so that way, as you meet on a regular basis, you can say, okay, in April we said we were going to do this and this person was going to be accountable for it. What are the updates? And that way it's transparent, everybody creates it together, and you can use that to keep the team oriented and anchored. One of my pet peeves is attending a meeting and spending the first 15 minutes with just kind of reorienting from the last meeting, and having that living document to refer back to can really orient everybody very quickly to the meeting. The other much more simple process is to use a structure that is just to do, being done, and done category. And I think of this as being a bulletin board with post-it notes. And you think about everything you need to do for the project, move the first steps to the doing column, work on those, and you just keep moving the sticky notes across. And it's a nice visual, and one thing that I like about that one a lot is you can see the accomplishments that you're doing as you move each sticky note to the done column.
Mm-hmm. Yeah, I would definitely agree with that. The other thing is, at the end of each meeting, I like to clearly articulate what are the next steps and who is responsible for them at the next meeting, and then sending out, make sure that somebody's taking minutes, not super detailed minutes, but just enough to remind people of what happened at the meeting. If they weren't there, they can be oriented without you having to go through that reorientation process at the next meeting, and then clearly outline what are the deliverables and who's responsible, so that the next time you get together, people also feel a sense of ownership and responsibility over the process. So, maybe somebody's going to get an article, another person's going to check in with a few patients, another person's going to check to see how much it costs to get something printed, and then send out an email or whatever communication method is most likely to be adopted by your team. It could be Google Documents, it could be Dropbox. Where are they going to most likely look to get the updates to the meeting and see what they're responsible for? And then send a reminder. Remember, we have a meeting in a week. These are the things you said you were going to do. If you're running into difficulties, let us know ahead of time. That we're not wasting time at the next meeting. I also hate having meetings just for the sake of having meetings, so sometimes asynchronous communication in between meetings can be a great time saver. My other thing is we tend to have a default hour-long meeting, and oftentimes I'll say, we don't have to have an hour-long meeting. If we can do this in a half an hour, great. People are busy, so I want to make sure that they know that we're respecting their time. We have a few more minutes for additional questions, so feel free to let us know if you have any more.
Well, it sounds like there aren't any other questions, so thank you all for attending. And as I said, this webinar we recorded it today, and so it will be available on our website, bh.wellness.org, within about 2 weeks. So thank you all for attending.